screen now?
Yes.
Yay, we did it. So that is what I get. I blocked third-party cookies because I was tired of everything being full on my computer, and Microsoft Teams isn't like that. So problem fixed. Well, hello everyone again. Where were we? We're on apple picking and fall and beauty. All right. So today we're going to be together for a little less than 2 hours. I will give a break, but this is designed to be a collaboration. This is designed to be a conversation because there is nothing worse than being talked at for 2 hours. And so I won't do that to you. So we're going to start off talking about prevention of lifestyle-related chronic health diseases through infant and child-focused nutrition interventions. If I can share, when I started Peapod, I was asked this yesterday by a patient, how did this idea come to you? Like, why are you even doing this? And there's a local public hospital here called Grady. And Grady is where most med school students train at. It's where I trained at as a nutrition intern. It's also where most of our low-income families go, individuals experiencing homelessness. We have people coming from county jails and prisons and shackled to their beds. And it's a really great place to learn because you see every kind of patient possible. And one of the first patients I saw, I was just a wide-eyed, nutrition intern in my 20s. I'm going to go change the world with my information about nutrition and health. And I walk in, and this woman, she was in her 60s, and she'd just come out of a diabetic coma. Blood sugar levels were in high 700s, low 800s. She's going to have to lose part of her toe, and she was going to be discharged shortly after that toe amputation. And so I was there to do her counseling to get her ready to manage her blood sugar levels outside the hospital. And I'm going in and I'm having this great conversation, and she's just like, yes, oh, of course. And yeah, she is affirming everything I'm saying. We're having this magical conversation. And I see on the little table, the hospital table, a 20-ounce Sunkist soda, just perched right there, closed. And I think, oh, it must be someone like her daughter or maybe a friend came by and they're just not in the room right now, but they're going to come back and grab their soda. Like, who else would it be for? She's here in the hospital, so she didn't go get it for herself. And as I'm leaving, she turns to me and she says, baby, can you just hand me my soda there before you leave? And I was just crushed because in that moment I realized that the coma, being in a coma for a week wasn't enough. Losing part of a toe is not enough. They were going to have to amputate the whole foot, but they worked until they figured out a way to take the minimal amount possible. If all of that wasn't enough, the education, because she understood the impact the diabetes was having on her life. She understood the changes that she needed to make. But culturally and in her environment and what she has been taught for those 6+ decades to get to that place, it wasn't enough to stop her from making this really harmful lifestyle related decisions that were ultimately probably going to end her life. And so that is what really made me decide to go into pediatrics and women's health. And that is to get on top of problems like that before they even start, to prevent that cycle of addiction to sugar and food and this disrelationship that we have with food in our country, and to ensure that families are growing up healthy, that children are growing up healthy, and that parents have the tools that they need to raise healthy children with good lifestyle habits, so that they are not in the hospital 60 years later, still wanting a Sunkist soda when they've been in a diabetic coma. So starting with that in mind, here are our objectives for this first hour. So we're going to educate. So everything we come at with is with cultural humility. So you'll hear a lot of terms around, there's cultural competency and all these other things, but it's really just taking where our families are at and using that as a base for all of our education. We're going to talk about some strategies to promote healthy adoption of the nutrition guidelines throughout the life cycle, focusing on our younger kids, our kids under 5. This talk is going to focus a lot on those first solid foods that we're starting and how that can begin to create change within a family when those children are ready to start solid foods. And then we're going to develop some methodologies to create some patient-centered care for nutrition. So as I said from the top, this is discussion. This will be collaborative. I value and want your feedback. I'm going to ask for your feedback a few times in the session. So there'll be multiple times that I'm going to stop sharing my screen so I can read all your comments coming in. Even later on today, I'll be taking some of your comments and actually putting them in the slides. So you'll be part of this conversation. So first poll question. It's like a pop quiz. So first poll question is, what age should an infant start solid foods? Are we at 3 months, 4 months, 5 months, 6 months? If you're thinking of a range, then pick a place on that range that you think would be the most appropriate. And I'll stop sharing for a second so I can see the poll. All right, answers coming in. Let's see here. I just realized this whole time my camera's been off. There we go. Okay. I'll give about not 2 minutes, but 30 more seconds. All right, it looks like our overwhelming amount of responses is 6 months. We have a few in between, no 3 months. That's great. That's great. And then I also see where we have some that are based on developmental readiness, when family is ready. Perfect. Well, all shall be revealed, but many of you are correct. Many of you are right. So the answer is 6 months. So and the recommendation in the US for a very, very long time was 4 to 6 months, for an incredibly long time. However, that was not consistent with the recommendations in the rest of the world. That wasn't consistent with the World Health Organization, with organizations like UNICEF. And now, finally, we have every major academic body and scientific body on board with the same age, and that is 6 months, at the minimum 6 months. So it doesn't mean that parents have to start right at 6 months, but we're talking about the American Academy of Pediatrics, American Academy of Family Physicians, the Academy, which is the Academy of Nutrition and Dietetics, World Health Organization. I mentioned things like UNICEF, NIH. It is now recognized that no child, whether they are formula fed or breastfed, should be started on any type of solid foods before 6 months of age. And so there's two basic rules for solid food introduction. The first rule is that we never, ever, ever put anything besides breast milk or formula in a baby's bottle. So why is that? Grandma says it's fine. It helps babies sleep better. You know, my mom did it and I'm fine. You know, my mom raised 12 kids and I'm great. But the challenge is that it's a major choking hazard. So when we think about adding cereal to a bottle, it does change the consistency of that milk. And really changing consistency of a milk that's going to a baby is something that a speech language pathologist does. And that's really only in a clinical inpatient setting or a supervised outpatient setting for very specific swallowing dysfunctions. It's not actually something that should be used for every child or for most children. But the biggest reason, the reason that we have, you know, all these folks on board with that 6 months at minimum for any type of solid foods for baby is the impact it has on the GI tract. So we now know that so much about our overall health is connected to our gut. And this is a big one. So when infants are born, they have what we call an open gut system. So that open gut system is kind of like a fishnet stocking. It has like these really big holes and gaps in it. When you see the stools or the poops of a breastfed baby, you see these like little chia seed looking things. Sorry if you had chia seeds this morning, but these little seeds in the stool. And those seeds are actually kind of showing you what those gaps are looking like in the intestines. They're really, really normal. That allows for those healthy, amazing, larger proteins that contain antibodies and all other sorts of good materials going into baby's body, going out into places in the body that they just don't in adults because we have a closed gut system. So as our little ones inch closer and closer to 6 months of age, they move from that open gut system to a closed gut system. We also see their stools begin to change. Even for an exclusively breastfed baby, they don't have CD stools for the entire time they're being breastfed. Those stools begin to change because their actual GI tract is changing. It is beginning to close up. And so that ensures that things that don't belong, floating around systemically in baby aren't getting there. So what we mean by that is if, let's say, we introduce a baby to avocado at 4 months of age, well, little parts of that avocado, little proteins and things can leave the intestines and go out into the body systemically. We don't want them there. They're not ready to be there. They're not ever supposed to be there. They're supposed to stay contained in the intestines. What is supposed to leave is breast milk, and what is supposed to leave is the properties in breast milk. And so we see higher incidence of long-term GI effects. We see higher incidence of food allergies when solid foods are started early. Autoimmune problems as well, because the immune system is now reacting to foreign bodies, to things that it's never supposed to react to. It's not supposed to be reacting to rice cereal. It's not supposed to be reacting to all these different proteins, to eggs and to dairy. It's not supposed to be. It's only supposed to be working with breast milk. And so that is one of the larger physiological reasons beyond choking hazards of why we don't put anything other than milk in our baby's bottles. And the second rule, and some of you alluded to it in the chat, is we want to wait until the child is developmentally ready to start solid foods. Well, what does that even mean, right? So developmentally ready to start solid foods mean the baby can sit straight, 100% straight up by themselves, no wobbling back and forth, but like really sitting up unassisted. This is super important for choking. This means if baby puts something in their mouth, that they're not going to put it in their mouth and then topple forward or move to the back or go side to side. So that's a really important element in just the safety around food. Then we want to make sure that the tongue thrust reflex has disappeared. So with the tongue thrust reflex disappearing, that is when when you put something in a baby's mouth and they stick their tongue out and give it right back to you. A lot of parents note this when they're beginning to feed solid foods on a spoon, that the baby will kick it out with their tongue. So that is the tongue thrust reflex. And it can be overridden. Any one of our instincts or reflexes, if we keep telling the body we don't need it anymore, it will go away. But we don't want it to go away. That's incredibly protective for a baby. So it ensures that if a child is too young to have something in their mouth and they don't choke, that if something goes in their mouth, they automatically spit it out. They get rid of it. They get rid of the things that aren't supposed to be in there. And that's a super, super important part of just keeping our little ones safe. But how do we ultimately know that our little ones are ready to start solid foods? They reach for it. They put it in their mouth. They chew it. They swallow it. Ta-da! They're ready. So what is not developmental readiness? A lot of times we'll hear, well, my baby is waking up so much at night now. You know, they're getting 4 or 5 months old and I cannot get them settled. They're nursing so much. They're just like nursing more than they ever did. But we know those are not signs of developmental readiness. Those are actually really normal parts of our infant development, of infant sleep cycles, that around 4 to 6 months, we have a lot of things going on. We have teething starting. We have big cognitive developmental leaps happening. We also have one of our last really big growth spurts happening. Of course, kids continue to have growth spurts, well into their teens, but these are some of our last huge growth spurts where we're seeing unprecedented growth. And so that is all really normal behavior. A lot of times I have folks come to my office wanting to start solid foods because their baby is just gaining weight so slowly, or they're too small for their age, or conversely, they're too big for their age, right? And I say none of these is actually a thing. You're never too big for your age. You're never too small for your age, unless you are failure to thrive. But every child's supposed to follow their own growth curve. That's going to be different for every single kid. I have a lot of parents in my office who are always comparing their child to their cousin. Or yesterday I had a set of twins and we're comparing these two fraternal twins and how they look and how they eat. And every child is individual and they're all going to follow their individual growth curve. But milk has something very special in it. So milk is a complete food. It has everything that baby needs. So if you truly have a child who is gaining weight too slowly, like clinically it's a problem, then milk is what they need. They need more milk, not more solid foods. An infant doesn't start eating and sit down and have, lovely, perfect meal with a protein and a grain and a starch and a fruit or a vegetable. They don't begin eating that way. So solid foods really inhibits the ability to quickly gain weight because babies are just learning how to eat. And what they are eating are not complete foods, but milk is always a complete food. So that is what we want to promote. So looking at some of the data that we currently have about the early introduction of solids. So we know among low-income families that somewhere between 22 and 33% start solid foods between 2 to 4 months of age. And a lot of our data comes from our WIC parents. WIC is such an important source of research for the entire research community because we learn a lot about infant feeding and child feeding from the families that you serve. So the top thing that is usually going to infants this young is rice cereal in the bottle. That would probably be our number one thing. And when parents were asked in some of these studies and focus groups, what they think about solid foods introduction, or why they would start solid foods that early. One said, no, I don't think it was really a plan, but I just think, she's kind of the right age. So they're just kind of like, I don't know, this seems right. And especially if this is a parent's first child. They're just kind of going off of, if they don't have the information, they're just going to play it by ear, see what their baby's saying to them. Another mom said, I didn't really know exactly when, or I really didn't know. I thought I'd just go off when she gave me the cue. What the cue is, who's to say, but just kind of going off of when that cue was given. Another study looking at low-income mothers' decision regarding when and why to introduce solid foods to their infants. Parents said, as soon as he turned 4 months, he was constantly feeding, so just constantly nursing. I thought he needed something more to put in his belly, something solid, to fill him up and satisfy him more. This is one that's pretty common. I think as nursing parents get a lot of feedback from the world that their milk is not enough. And that if baby is nursing more often, if baby is not nursing like their friend's baby or someone they saw on the internet, that there's something wrong. We talked about before that it's normal to have a higher intake of milk around these big times of developmental leaps between 4 and 6 months. But a lot of parents take that cue as a cue that they're not enough. That guilt starts early, that mother's guilt starts early, and we start putting it on ourselves that what we're producing is not enough for our little ones. That's just not the case. Another parent said, since she's 4 months, she eats the cereal in the bottle, and now I'm giving her mashed potatoes and pudding. She's tasting it. She's not really eating it. She doesn't have the ability to chew and swallow yet. So here's some more parents' perceptions of the recommendations that they have been given by their providers. And these are once again coming from WIC parents. One parent says, how do they know that 4 to 6 months is the appropriate time for every child to wait? Which is a great question. And we're going to talk about that data of how we know that. And I do it, add cereal to the bottle to help her sleep through the night. That 4 to 6 months of age is when the infants start to get much hungrier. Mom knows best, and she's not going to tell you anything wrong. And when the mom in this situation was grandmother, that grandmother knows best, and she's not going to tell her own child anything wrong about feeding their grandchild. So I would love to know, what have parents shared with you about starting solids or infant cereal, because that's considered solid foods? What information have they shared with you? What feedback are you hearing? And what kind of foods are they usually starting with and when? I'll jump out so I can see you all in the chat. Let's see. So great. I'm seeing some, which we hear a lot as well. I hear that down here as well, that my doctor said I could start at 4 months. So that's what that's where I started. Yeah. Oh, I love this from Mitchell K, that our doctor pushed us to start between 4 to 6 months. My second child wasn't even ready until 9 months. We certainly have that happen where a child is not ready to eat at all at that time. 6 months is the age, but when you're thinking about developmental readiness, one of the other mothers mentioned in the study that I put up that, even though she had started introducing foods to her child, pudding and mashed potatoes, that the child really wasn't eating it. They're just kind of like mushing it around in their mouth. Let's see. Solids are just easier. Yes, solids are just easier. We're going to talk a bit this afternoon about what that is telling us about the support system that those parents have, about how feeding is going for them. That is a very subtle way of telling us that nursing or bottle feeding or whatever method they're using of feeding has been challenging for them. That has been a challenging road, and they are looking for something externally to make their lives a little bit easier. Sarah, that we've had doctors write prescriptions for cereal in bottles. So have we. It's so frustrating. And I'm not sure in your situation, Sarah, but when I've had doctors write prescriptions for cereal in bottles, it's usually for all the things that it would not be indicated for. So I've had them write it for reflux. I've had them write it for growth, and we know it doesn't help growth. But that's where we come in as the experts. Oh, Emily Adams said, I find my parents are doing baby-led weaning rather than baby cereals or purees. We have a mix here in Georgia. I'd say we have a mix between the baby-led weaning and cereals and purees. And we'll talk a little bit about both. And then Lindsay brings up a really good point, that we were told to introduce peanuts and eggs between 4 to 6 months to prevent allergies. That is a really great place to jump off from as we move into the next part of our discussion here, about the data around food allergies. So we now know that for every food allergen besides cow's milk, that introducing them at around 6 months of age is really helpful in preventing food allergies later on. In the States, we were a little backwards, and we had parents not introducing these allergenic foods until much later on in life. And our kids in the US have the highest rates of allergies in the world. And they're like, what's that about? Well, it's because the data clearly shows worldwide, and now in the US as well, that we should be introducing allergenic foods when we introduce any other solid foods. But 6 months is really the age. The challenging thing is, in the US, as I talked about in the beginning, the recommendations were 4 to 6 months for a very, very long time. I've spoken to pediatricians who are well respected in our community who are still recommending 4 to 6 months instead of 6 months. And I asked them point blank why. And the reason that I was given was, well, I understand the recommendation. I know the recommendation, and the science makes sense. But I've been saying 4 to 6 months for 30 years. And I have kids who are in my practice who are coming from adults who I saw as children. And so everyone kind of turned out fine. So I still say 4 to 6 months. Is that scientific based? No. Is it evidence based? No. We know that the everything is fine or everybody is fine is a real challenging one, because it really just means everyone lived, that everyone that you worked with lived, and they're here. But we know that, you know, the data is very clear, that for the long-term health of children and adults, that 6 months is that age. So let's jump back into our presentation here. So what are the benefits of delaying solid foods at or past 6 months? It's a great protection from illness. If a baby is being nursed and they get those antibodies, and nothing but those antibodies for a full 6 months, and then as we're introducing complementary foods, they're still getting that great protection. Allows the digestive system time to mature, decreases the risk of food allergies for reasons we talked about before, and it protects baby from iron deficiency anemia. This is often one reason that you hear that babies need to have cereal in their bottle, or be introduced to cereals first. So it's about 7 years ago now that recommendation changed, that we were no longer recommending infant cereal. Infant cereal is not a recommendation as starting as the first food. What is a recommendation for first foods is high iron foods. So introducing things like beans, legumes, really, let's make sure everyone's on mute, put really iron-rich foods. For babies who are formula fed, their formula already has iron in it, so they're doing fine on iron. For babies who are breastfed, the mother or the nursing parent is making human iron for human babies. It is the most bioavailable iron that any human being can have. And so we actually see less iron deficient anemia in our breastfed babies. And it used to be thought it was the other way around. So what the original thought was, we look at the composition, just scientifically pulling out the nutrient profile of infant formula and of breast milk. And when you pull these two files out, you look, you're like, oh, wow. It looks like on paper, there's a lot less iron in breast milk than there is in formula. As we said, that iron in breast milk is over 85 to 90% bioavailable. The iron in formula is about 10 to 30% bioavailable. And so while one might look like it has higher numbers, the iron in breast milk is actually the easiest to absorb and the best for baby. So we no longer have that recommendation that babies need to get rice cereal or any other kind of infant cereal first to get more iron, because all the baby cereals are just some type of starch with added iron in it. That's really all they are. Whether it's organic or it's oat, barley, rice, it's all really just some type of starch and iron. Some of our other benefits: it helps protect babies from future obesity. How does it do that? How in the world does that happen? Well, when we delay solid foods past 6 months, then we get a baby like the one in this picture. We get a baby who is able to, at this age, sit up on their own and start bringing food to their mouth on their own. They aren't relying on somebody else to tell them when they are full, to tell them when they are hungry. It's time to eat. You have to eat this much. Instead, we are presenting food to baby and letting them choose how much they eat. That's super important for our hunger and satiety or fullness cues later on in life. This is one of the reasons why breastfeeding is also protective of obesity later on in life, because of that slow way that baby's belly is filled up for most moms. Some moms, that milk is just flowing super fast. But it teaches babies, so nursing already is teaching babies when they are full, when they are hungry, they are listening to their bodies. It seems so strange to think about a baby listening to their body, but they are. They know when they are hungry, and when they are full and ready, they stop eating. Bottle-fed babies, it's a bit more of a challenge. And so we've seen it, clinical studies have now shown that no matter what is in a bottle, whether it's breast milk or formula, now that we have more parents who are exclusively pumping, that babies tend to be overfed with a bottle. And the overfeeding comes from this, the child's need to suck, swallow, breathe, suck, swallow, breathe. And so if at the breast, if the milk is flowing slowly, then they have time to suck, swallow, breathe. With a bottle, when that milk is, if the milk is just flowing into them, they can't stop sucking because they have to keep breathing. And so they take in more food than they need. And this same thing goes into starting solid foods. It also helps mom maintain her milk supply and makes starting solid foods so much easier. So our quote unquote, you can't see me, but I'm doing my little quote signs here, problem with purees is discourages self-regulation. It inhibits chewing. As we talked about, purees are not, whole foods. And when they are, they don't taste great if you kind of put all the things together. And it can create or exacerbate feeding issues. As a feeding therapist, I see a lot of issues connected to children who are only provided purees as a solid food source. For infants under 6 months, it was mandatory to provide them purees. They didn't have the ability to sit up and properly chew or bring food to their mouth. And so it's one of the great advantages for starting after 6 months is that you don't have to start with purees. And if a family chooses to start with purees, that's completely fine. But by the time the child is about 7 months, they also have a nice pincer grasp. And so it's a great developmental tool to be able to pick up foods and bring them to their mouth and practicing that pincer grasp. So benefits to our families of starting with family foods. And this is my little babe, like 8 years ago. So there's no extra work for the parents. It's less expensive, very little stress. There is, of course, initially stress with any new thing we do, but much less stress. We're not begging or tricking or bribing kids into eating. As we talked about, encourages self-regulation, encourages independence. A few people mentioned that babies are kind of reaching for that food already. They want to be part of the family table, so let's let them be part of the family table. Also develops that hand-eye coordination once they have their pincer grasp on. Really great to start bringing things to their mouth, learning where to put foods in their mouth to prevent choking and to learn how to chew. And it brings in a trust of new foods. So how can we translate this over to our parents? Our parents and our caregivers are really our child's role model. They're the child's role model in everything they do. They determine, that's what a child's looking at to learn their first words, to learn their vocabulary, to learn how to walk, to learn how to do everything. It's often why you see children who are second or third children kind of doing everything faster. They have a whole lot of examples around them of how things can be done. So a child will typically not eat what a parent doesn't eat. We get some complaints from parents like they won't eat anything on their plate, but everything on my plate they'll grab for. They want to sit in my lap and play with my food, but they don't want to eat their food. And that's an important evolutionary trait that was really essential for survival of little tiny humans. If you see the adults around you who are still living and breathing and doing great, eating something, then that's probably the thing to eat. If you don't see your parents or your siblings eating off of that bush of berries, then maybe that's not the bush of berries for you. Maybe someone else found out a long time ago that those berries are poisonous. So it really helps babies to trust foods and to identify harmful versus healthful foods. Now, this means everything. So if the child sees parents eating, cookies, they're like, cookies, that's a safe food. I should be eating that as well. So what is this model? We've all seen the plate model. We all know the plate model. I really like the Harvard School of Public Health model because it includes that important water on the side, our healthy oils, and gives some really great examples of different kinds of proteins that proteins, fruits, vegetables, and whole grains that are really important in the diet. So everyone's diet doesn't look like this. As the dietitian, this is one of the first things we work on in office is for folks' diets to start mirroring what this plate looks like. It's, usually one meal a day. We have this down, but not all. And so if we're presenting this to parents, it's important that we explain this in a way that's not fostering shame. What if they don't eat breakfast? They are running around. They are so busy. They have, 2 or 3 kids and they're working and they're just trying to get anything on the table for these kids. And so this can bring up guilt about a parent's own diet, shame about not being able to afford what they consider to be healthy foods. This is really important is what they consider versus a perception versus reality of healthy foods. And we'll talk about how to help them with that. And so we want to frame food modeling as an opportunity for the entire family to learn new ways of meal planning, grocery shopping, and preparing foods. So having a child start solid foods is a really great opportunity for everyone in the family to get healthier, not for parents to go on a diet or to do anything dramatic, but to slowly start to foster healthier eating habits. And so we want to focus on the benefits to the parents in this situation. So a couple slides back, I was talking about all of these great benefits to starting solid foods at 6 months and starting with these family foods. We are always talking about how important nutrition is for babies and for children. We're always talking about how important breastfeeding is for babies. Parents are not hearing what's in it for them. And when you're exhausted and when you're trying so hard and everything is about this little person, you need something for you. So we really have to start talking about the benefits of healthy eating and food modeling for our parents. And some of those benefits are things that they're looking for, like weight management, preventing type 2 diabetes, hypertension, high cholesterol, strokes, many types of cancers, increasing longevity so they can be with their kids and their grandkids in the future, increase energy and better mental health and clarity. There's a lot that is in it for parents. So as much as we want to talk about this is best for baby, this is best for baby, what is best for parents as well? So our mealtime rules. Our mealtime rules is that everyone in this family eating model puts a little bit of something on their plate. Everyone, we're cooking one meal. One thing is happening here. We want to baby size the baby's eating environment. So toddler spoons, forks, plates, their own setting. I say their own setting at the table, but if family doesn't eat at a table, that's not a problem. Their own setting on the floor, their own setting at the bar stool or wherever they're eating, their own little space. Turning down the noise, turning off the screens, and just allowing that to be family time. Family does not mean a family of 4, might mean a family of 3, might be just the parent and the child. It could be grandma and the child. It could be babysitter and the child, whatever that family is. And then offering a little small cup of water, not juice, at a meal, and not hurrying or distracting the baby. So other just mechanical things that we can do to help raise an adventurous eater. Waiting until a meal is finished to wipe a child down. It's nothing more annoying. You're in the middle of just enjoying the best meal of your life, and then someone comes in with a cold washcloth or a cold wipe, just starts wiping you down. I often see this too with nursing parents when their child is in the middle of nursing and they get milk on them and they stop the process to start wiping them down. Babies are so upset, as they should be. They're eating, they're enjoying themselves. Let's let them eat and enjoy, and then we'll do the cleanup later. And then one of the big things is avoiding added sugar. And in the next hour, we'll talk a little bit more about that avoiding added sugar piece and how it ties into long-term health and longevity. So being mindful of time here. So in this last hour here, we want to go slow and be really consistent. So these changes take time. We're asking for some pretty radical changes for many of our families. So there's 4 domains that I like to work on. Meal planning is the first. We work on healthy snacking, then on the sugar sweetened beverages, then on movement. So we want to start discussing these domains first time we're meeting with a family. And it sounds like from the top of our talk today that y'all are about to have so many amazing resources and the text messaging and all sorts of things to have more talk time, touch points with the families that you serve. So that's really exciting to be able to get these messages across in really small, succinct ways. So these discussions start prenatally. The prenatal time is one of my favorite times because parents are so ready to make healthy changes when they're pregnant. Many times this is the healthiest that a parent is going to be is when they're pregnant. I see parents making giant changes. All of a sudden they've gone plant-based while they're pregnant, and all of a sudden they're eating organic and reading every label when they're pregnant, and they never would have done that before. And then if without the proper support, a lot of them stop doing that once baby is born, just because life stressors and time. So we would want to start discussing this prenatally and then continuing to follow up postpartum. When we're talking about nursing, when we're talking about infant feeding, we should also be talking about nutrition. We should also be making sure that our parents are getting something to eat as well. Are you nourishing yourself? Are you taking care of yourself? And then any follow-up or well checks, we are consistently talking about nutrition and consistently talking about family nutrition, not just focusing on one member of the family, but the entire family. We want to go one domain at a time because too much information is just too much information and it cannot be absorbed well. So starting off with meal planning, that first domain, we want it to be culturally relevant. So as I said with meal planning, a lot of times we talk about the foods that we want, like, avocado and strawberries and these types of things. What if the family doesn't eat any of those things? Then they're going to listen to the information you're telling them and the foods that you're mentioning, and then they're going to go home and do their own thing. Here we have a really large refugee population in Clarkston, Georgia. It's one of the larger homes for refugees in the country. And then we also have a lot of immigrant families. And I'll talk to families and they're like, okay, are you going to make me eat this American food? Because I only eat Nigerian food. I'm like, no, of course you don't have to start eating American food. Americans aren't known for our health, so you don't have to start eating American food. What do you eat? What do you like to eat? What are the components of the food you're eating? Let's turn that into closer to what that plate was looking like. And so we want it to be culturally relevant. We need to ask folks what they are eating, getting that 24-hour dietary recall so that we can tailor or show them how to tailor a healthy meal plan to them. So I ask you, what did you have for breakfast this morning? And we're going to tailor that into something the whole family can eat. If you haven't had breakfast yet, then you can tell me what you ate for dinner last night. I will start with, so for breakfast this morning, I had some Siggy's plant-based yogurt with berries and granola, and my favorite chai latte that no one else in my family likes, but is chai and turmeric and 2 types of mushroom powder and matcha. No one else likes this but me. So let me look into the chat and see what we have. All right, Sarah had bananas and pistachios. I know it was a quick morning too. A lot of coffee. We're getting our caffeine fix this morning. Okay, so we have eggs are a favorite, coffee's a favorite. Oh, hummus. What is this? Let me go back to this. Hummus, toast with spinach, shredded carrots, and avocado. Sam, you win. I just made my poor little yogurt sound so sad. Okay, so I'm going to pull 3 of these. And how could we make this something that a whole entire family could eat? So I will take this. Okay, so Ashley has egg, tomato, and bell pepper burrito. So like a little breakfast burrito situation. So this is great. It has everything we need. It has a fruit, a vegetable, a protein, and a carb. It's all together in one. All of those components can be fed to a little one, to a baby over 6 months of age. So we'll have to deconstruct it a little bit. They can't eat a burrito, but they can have some scrambled eggs. They can have some tomatoes cut up and some peppers cut up, maybe soften those peppers. And we can tear up that tortilla for them to eat the tortilla. So there we go. That's how we break down a meal to go with what a baby can eat. If we went up, let's see, someone who was going quick this morning. Let's see. All right. We had one. Coffee and toast. It was a quick morning, coffee and toast. So this is a great opportunity to elevate the entire meal, right? And it's so interesting. I see it a lot where parents will tell me they like barely ate anything and then their child had this amazing meal. And you're like, but wait, you were cooking the amazing meal. Why didn't you eat any of it? But with like a coffee and toast morning. So we have toast. We can throw some peanut butter or some kind of nut butter on that as a protein and add a fruit. And any kind of fruit. Doesn't matter to me what kind of fruit it is. And now we have a complete meal. And just that fast. It takes very little extra time. We're not really preparing much more. The biggest thing that we're preparing there is the toast itself. And then we have waffles and bacon. So babies love waffles. And bacon, of course. So all we need to do to add is a little fruit to that. And now we have a complete meal. So super, super easy. For ginger, moondrop grapes, which are so yummy, and an apple. We just need a protein with that. Maybe for yourself, a handful of nuts. For baby, that could be eggs, it could be beans, it could be anything else. And like an English muffin with it. So something really, really quick. So we want to start to move around and ask our parents what they're eating, and then adding in proteins, fruits, vegetables, carbs as needed to make a whole meal for themselves and for baby. And families usually find like, oh my gosh, yeah, because I was starving. I'm so starving throughout the day, all day long. I never eat. And so we really want our parents eating 3 times a day. This translates to our kids eating 3 times a day. If our parents have a fruit with breakfast, our kids have a fruit with breakfast. Same for vegetables with lunch and dinner. So healthy snacks. I'm often asking folks, what are they snacking on? What do their kids snack? And some will say, oh, we don't eat snacks. We don't keep snacks in the house. I'm like, well, we don't keep snacks in the house. But when they're thinking of snacking, they're thinking of unhealthy foods. They're thinking of what we call our sometimes foods, chips, cookies, candy, ice cream. Those aren't actually snacks. They're sometimes foods, they're occasional foods, but they're not snacks. So snacking is not a bad thing. Snacking is actually an incredibly important thing for growing children. When foods are first introduced for a nursing baby, they're getting solid foods and they're nursing. So they're getting food, every 2 to 3 hours out the day. And that never really changes for kids or really for adults. They still need to eat every 2 to 3 hours throughout the day. So snacks are going to be really important. So we want to redefine what snacks are. And snacks are actually really, really cheap. So here's some snacks under $1. Some of them are the things we already ate this morning. So grapes, peanuts, things like cheese sticks, baby carrots. Someone had pistachios this morning for breakfast. Pistachios, hard-boiled eggs, popcorn. These are all really simple, easy snacks. They don't have to be this beautiful, but it's so nice to have pretty things like this for presentation purposes. When I was going through this again last night, my daughter came in and she was like, what is that? I see healthy snacking and, oh, I thought it was junk food, but those are all fruits. I said, yes, it's all good stuff. Redefining what that healthy snacking really means. And it's helpful to have lists of resources of what snacks are. And then our sugar sweetened beverages. So we wanted to find what juice is. Sometimes we'll have a family say that that they drink juice, but they'll be like, oh, it's natural juice, or that juice is actually a sports drink, or that juice is actually a fruit juice cocktail, like a cran raspberry or something like that, or cran apple. Or they think they're doing something really healthy by getting those bottled smoothies, but they're really just like pear juice and apple juice mixed together with some green things in them.
Alicia, yeah. Sorry to interrupt you, but are you sharing your screen? We can't see it if you are.
Oh, okay, I am. Let's go back to it. Thank you for interrupting me.
Sorry about that. Thank you.
I'm just talking away. You guys are just like, what is it?
It's great.
You're like,
it's okay because I was so entertained by listening to you. I didn't even notice the screen missing.
You're missing all the joys of fruits. What I'm sad about is you can't see my face and all my hand gestures. I'm just going crazy. So, but finding out what the sugar sweetened beverages are. And we're going to talk a lot about this in the next talk about the role that sugar plays. A lot of people think about sugar just in terms of diabetes or blood sugar levels. But as we'll talk about in the next talk, a lot of it has to do with heart health. A lot of it has to do with palatability of food and the food choices that children make overall. And really for kids, water and milk is it. We don't need juices. We don't need sodas, Sunny D, Kool-Aid. There's often the perception that these things are treats, that these things are very important parts of just culturally being a child in America. But that is all in that cultural aspect, that how we frame them. And so especially for kids under 2, they shouldn't have anything but water or milk. But asking about the sugar sweetened beverages and trying to find alternatives to those. And then the last part is movement. We need a family plan for movement. It's so big. So depending on the neighborhood, some families don't feel like they live in a safe enough neighborhood to go outside and take walks, or the playground's not very safe. And so we need other ways of getting movement in. A lot of schools now don't even have a lot of movement in the school. There's recess times are cut. one, if we can find any good things from the pandemic, is that a lot of schools and preschools and kindergartens are finding more ways to get kids outside. So that's fantastic. I'm hearing more lunches outside, more classes and interactive time outside. But families can do things inside together, and it's a great way to bond. Finding an activity that both kids and parents can do together, something like free Cosmic Kids Yoga on YouTube, playing Twister, anything that gets them up and moving. Of course, going outside and outdoors is the absolute best, but if that's not possible, then finding what is possible inside the home. And I should say without internet access as well, what is going to be possible. So I will stop here again. I'm going to stop sharing so that I can see everybody and turn on my camera. Yay, I have a camera again. Perfect. So we'll stop for a quick 5 minutes for questions. I'll give everyone a break, and our technical difficulties put us back a little bit. So I'm going to jump right into our next one after a little break. But any questions so far? All right. Seeing no questions so far, we'll go up and throw up a quick 5-minute break. Everyone stretch. We talked about that movement. It's a good time to get some movement in. And we'll come back in 5. All right, we're all coming back. I decided to stand up. So for the next hour, I'll be standing. I invite you to also stand and move and wiggle. I work with kids a lot via Zoom now, and one had a super cool room. He had a swing in his room, and he started swinging on his swing. And I said, listen, as long as you can hear me, that's fine. As long as we can talk back and forth, swing away. So as we get started, I want to address some questions that came up in the chat while we were on our little break. So one from Anna, that I love the comment about not needing to be at a table. A lot of our families do not have, wondering how you discuss distractions. So that there can be a challenge without having a table, that then you have runners. Our kids are like, off I go then. So one of those is if we have a kid who's up and moving a lot, setting realistic expectations on how long a child can sit and do anything. So expecting younger kids to be able to stay at the table, you know, somewhere between 5 and 10 minutes, needing a wiggle break, come back, or stay at the family seating area, 5 or 10 minutes, wiggle break and come back. So that's a really good expectation to set up there. But you typically, a lot of times, if culturally families don't have a table, so if they're, let's say, all eating on the couch together, we can all eat at the couch together, but not with the television on. We're eating, we're being intentional about that time. A big challenge is that we often don't have a lot of intentionality around what we're eating or our meal times together, and we're really fractured. And so when we're dealing with this, you know, 0 to 5 crowd, this is a really important opportunity to start these moments where we are eating together as whatever the family structure is, whether it's on a couch, whether it's in the car, whether it's at a table, but creating that moment wherever we are, distraction-free. And for a lot of us who were raised in the 80s and 90s, that television was always on in the background. So it is a big cultural shift to like, wait, we're supposed to do what? Without the 5 o'clock news on in the background. That was always the fight growing up, is who got to sit where at the table, because only 2 of the seats faced the television and the other 2 seats faced away. So it's like, who can get to the table, to the good spot first? And then how do you convince slightly older siblings to not sneak the baby's food? That's a challenging one. But it's rationalizing as best we can with it. Oh, baby brother or sister can't chew that food yet. Oh, that they're not quite ready yet for that for their tummy, but they will soon. Thank you so much for being such a good big brother, a good big sister, and wanting to share your food. That is so great sharing. But right now, baby's just drinking milk. But soon, I will let you know as soon as baby can share that food with you. So keeping it really, really positive. And then Michael says, our WIC team at MMCA just did an ergonomics assessment, and that will help tremendously. Yes, self-care. Thank you, Michael. All right, so we're going to jump in. This next part was supposed to be an hour. We're going to try to get it in like 40 minutes. Let's see what we can do. So I'm going to start sharing again, because I'm determined to keep us on time. Okay. Let's move out of here. Oops. All right, back to sharing. All right, in this next one, we're going to be creating more of those connections. How do we translate over some data? So we're going to do some deep dives into data into changing nutrition and physical activity to increase those lifestyle related healthy choices. We're going to dive right into the data. So I hope you love data. So, the amazing thing is we have so much great new research coming out. The pandemic has been a wealth of information and knowledge. And now that we're a year and a half in, a lot of that research is coming back. So this is a recent report that just came out within the last couple of weeks from the CDC. It's the Morbidity and Mortality Weekly Report. And it has shown that kids and teens' rate of body mass index increase has doubled during the pandemic compared to prior years. So obesity rose by about 19.3% in 2019. Last year, it rose by 22.4%. For a variety of reasons. One of them is just being more sedentary. Being inside. If you have a parent who's trying to work from home, kids trying to do school from home, there's not a lot of opportunity to go outside for a, homeschool recess. Also, the eating habits at home. Suddenly you have a parent who's responsible for 3 meals a day and 2 to 3 snacks, while also balancing their own life, their own mental health, their own work, other children in the house. So it became a really challenging time that we're seeing health consequences of. So what are some of these physiological, so the physical implications for childhood obesity? And with the rates rising directly due to the pandemic, what does this look like for our kids long term? So childhood obesity, it predisposes children in childhood and in adulthood to insulin resistance, type 2 diabetes, hypertension, hyperlipidemia, liver disease, kidney disease, and can also cause reproductive dysfunction in adults, which we will talk about a little bit later on. So this is why I'm so passionate about working with children, because it changes the adults that they will become. So some of the psychological implications. So we also see that in our children who are currently battling pediatric obesity, we're seeing lower self-esteem. We see depression, higher rates of body dissatisfaction, feeling a loss of control around eating, a loss of control around food, feeling powerless about food, feeling powerless about their body. Unhealthy and extreme weight control behaviors, dieting at a young age. I had a 5-year-old come in who's concerned about dieting, who is talking to me about keto. And it sounds crazy and I laugh about it, but it's startling to have kids at such a young age thinking about these extreme things to do to their bodies. That is also another implication from the pandemic, is that if kids and adults are in the same house 24 hours a day, then they're going to hear things they didn't hear before. They're going to hear their parents talking about diets. They're going to hear things on the news. They're just hearing more. Then there's that social stigma of obesity, which is changing, thankfully, but is still very much there. And a decrease in the health-related quality of life for those little ones. So what is our symptomology of obesity? A range of symptoms. So anything from GERD, which is heartburn, high blood pressure, high cholesterol, to breathing disorders like sleep apnea, COPD. Not a lot of people think about it, but 70% of cancers are lifestyle related, 70%. So we're talking prostate cancer, bowel and colon cancer, breast and uterine cancer. Many of these are linked to our lifestyle. It's not just smoking and lung cancer. So only about 30% of cancers are not lifestyle related. So coronary heart disease, as we talked about, depression, liver, gallbladder problems, joint disease, pain in the knees, lower back, all of these are symptoms of obesity. So globally and worldwide, about 2.1 billion adults are overweight or obese. The highest rates are right here in the US. We have the highest, we're number 1, followed by our neighbors to the north and south, Mexico and Canada. And then you see it drops significantly. So we're talking 42% in the US, 32% in Mexico, 25% in Canada. The next biggest country is Switzerland at 4%. So that is a dramatic difference. In the US, even a third of our pets are obese. So overeating, excess, it's part of our culture. If our pets are obese, it's not just our genetics or other things. It is our lifestyle. So the prevalence in the US, and this is not counting the most recent data that just came out a couple weeks ago. This is our data looking at 2017 to 2018. You'll see that obesity is more prevalent in women than men, more prevalent in our folks 40 to 59, more prevalent in non-Hispanic Blacks than going for our non-Hispanic whites and then the Hispanic population. And that obesity has been on a steady increase. We had a little dip there for a second, and then we went right back to increasing in the US. And severe obesity or morbid obesity is also on the rise. You see, we've pretty much doubled, almost doubled the rate of morbid obesity since the early aughts. So this is incredibly recent data. So this just came out a few weeks ago as well, looking at the ethnic disparities between the prevalence of obesity in preschool age children specifically. So we're seeing in this demographic, as opposed to adults, you see it higher with women. In children, you see it higher with boys. It's largely a cultural thing. We have this thing of, oh, he's just a big boy, so we kind of let it go a little bit longer in boys than we do with girls. And they also see a very different in the disparity by ethnicity, with Native and Indigenous Americans having some of the highest rates of obesity among our preschool age children. Followed by non-Hispanic Blacks, non-Hispanic whites, then Asians usually have the lowest rate. So switching gears to pregnancy and obesity. So weight gain during pregnancy does depend on pre-pregnancy BMI. It's a third, a third, a third. So a third of women gain too much weight, a third gain the right amount, a third gain too little. But we do see the most excessive weight gain in individuals who are already overweight or obese prior to pregnancy. So in the group where we want to see the least amount of weight gain is the group that we see the most weight gain, which also tells us that those who are going into pregnancy at a healthy weight are really maintaining those healthy habits throughout their pregnancy. And that those who do not go into pregnancy at a healthy weight are usually not making those big lifestyle changes that we're looking for. So the consequences of obesity in our women of childbearing age, it can decrease fertility. It can also lower sperm quantity and quality. We'll talk about this a little bit more later. Increase the risk of endometriosis. It can also decrease the effectiveness of oral contraception because of the way that fat works in our body. We're going to talk about how fat is a dynamic really organ in our bodies. Individuals who are obese are less likely to breastfeed, have higher rates of unintended pregnancy and abortion, and increased risk of C-section. So what is BMI? What is this thing we're talking about? BMI is simply a statistical tool. It's an objective calculation. It is not based on our feelings or it makes no judgments. It does not tell us morally who we are. It is just an objective calculation. It's an evidence-based calculation, and it is a great predictor of disease risk. So oftentimes I hear families say, well, they say that I'm obese. They say that I'm overweight, but I love the way I look. I love the way I feel. And it's amazing that they love the way they look. They love the way they feel. But the fact is that the BMI that they're in does increase their risk of many diseases. It does increase that symptomology of disease. So it's not a value judgment. It is simply, this category of weight, of BMI, has an increased risk of these things. Increased risk does not mean 100% of folks are going to have it. It just means that increased risk. So what BMI is not a body fat percentage. So a BMI of 30 does not mean you are 30% fat. It is definitely not a tool for shame. Like I said, it's not a moral compass, and it's not a tool for judgment. It's just a scientific tool. So when we talk about BMI, when we talk about some of the consequences of obesity and overweight, we are not talking about a judgment on that person. It is just the numbers. It's just the data. So what is body fat? Why does obesity cause some of these things like endocrine disruption and fertility issues? Because it's a living organism. It's not just a static thing in the body. It facilitates the synthesis of vitamin D from the sunlight. It facilitates the absorption and utilization of A, D, E, and K, vitamin K, which is also made in our gut, really important. It's essential for cellular function. It's wrapped around every one of our brain cells. It's wrapped around our heart. It is so important for cellular function. And it also synthesizes hormones. So there's a few hormones. I'm going to actually start at the last one and move my way forward. So we're going to start with estrogen. So estrogen, of course, is produced in the ovaries, but it is also produced in body fat. And so that is why it can have effects on fertility. That is why sometimes we see men who are overweight or obese have what appears to be breast tissue that is actually active breast tissue because of higher estrogen levels. And so fat makes estrogen. It is next to the ovaries, our next biggest place where it produces estrogen. Ghrelin is another fat hormone. It's our hunger hormone. It's released when the stomach is empty, and our fat helps to communicate those messages. Then there's leptin, our satiety hormone, the hormone that tells us that we are full. And then insulin. Insulin is the main fat storage hormone. This is what tells our body whether or not that we store fat or we get rid of it and use it up. So when we talk about obesity, raising the risk of insulin resistance, that raises the risk of how our bodies are going to decide what to do with food, and whether or not we're going to move from overweight to obesity because of that insulin resistant. It also tells our body when to break fats down. So it's incredibly, incredibly important. Insulin does so much more than just regulate blood sugar. A lot of people just focus on it with diabetes, but it is a lot more than just diabetes. So our effect of obesity, overweight on children. So we know now, this is also a very recent study that just came out in the last month, that weight loss in childhood may protect boys against future infertility. Typically talking about weight loss for children is super, super taboo. We want them to grow. We do not want them to focus on losing weight. But some of the natural things that we do to help to change lifestyle behaviors like increase exercise, changing over to a healthier diet for the entire family, just naturally the children begin to lose a little weight and then they grow. This is the great thing about kids. They just keep growing and growing and growing. So in this study from the European Society for Pediatric Endocrinology, they found that as boys lost weight over this 3-month period, they had improved insulin levels and increased testosterone levels, and those estrogen levels started to move down. And this translates into higher fertility in later age. So the little things we do now with our kids make a big difference for their future. So how do we break this cycle, right? It's a big one. So we want to start, I'm going to start in the middle here with aging. A lot of people think many of the diseases that we discussed today are just normal parts of aging. They think as you get older, you just get diabetes. You get older and your blood pressure goes up and your cholesterol goes up. Your joints start to hurt. That's just a normal part of aging, but it's not. Chronic disease is not a normal part of aging. And so that is really important to communicate when we're talking about chronic disease, that this is not the normal progression of life. So a great way to jump into this conversation is to ask, is anyone in your family living with one of these diseases, with diabetes, with high blood pressure, high cholesterol, cancers, and helping them understand that they can break that cycle, that it's not inevitable, that just because their mom and their grandma had diabetes, that they will have diabetes. I'll share that in my family. My grandfather passed away from complications with diabetes. My mother had diabetes that she has reversed. My grandmother had diabetes that she has also reversed. And the reason that they were so motivated to reverse that diabetes is because of the rate of death in our family because of it. And then all of those people gave birth to a dietitian. And now this is a big part of what we do. And so the language we use is really important. Once again, wanted to take any value judgments away, to take any shame away. That we're going to talk about some ways to start preventing these kinds of diseases in your little one right from the start. It's not inevitable that your little one is going to, 50 years from now, have heart disease. This is something that we can change. This is something that we can empower our families with. So the foundations, one of the big foundations is our diet culture. I've kind of alluded to it a little bit. We're going to talk a bit about more of that. We're constantly fighting food in this culture. We're constantly dieting. There's always something new. It was low fat, and then it was high fat, and then it was, carbs are the devil. Carbs are great. So we're really obsessed with this idea of fat in our culture without understanding what fat is. And it's kind of a popular opinion to be unhappy with your body. It's just kind of what we talk about, like, oh, the stomach, I just want to get rid of it. Oh, my thighs. Oh, God, I'm thinking about doing this to modify this part of my body. It's just what a normal conversation is in our culture. So we're coming here, a no judgment, no guilt zone with the next question I'm going to ask you. So, and because of this, we're going to put it up as a poll. So you don't have to put your name in. But how many times have you attempted a diet or to restrict calories or exercise for the purpose of weight loss in the last 12 months? And you can choose 1 time, 2 times, 3 times, or more than 3. We'll wait to get that poll going.
Alicia, could you actually have type it from your slides, because I don't have a copy of them? Could you just throw your slide back up and then I can put it in the chat?
Absolutely.
Thank you.
And there we go. Yeah, I can't see everyone's faces when I'm on presentation mode, so I like to jump off just to see you. All right, now I'm going to peek in. Let's peek in at these poll results.
Kyle, has it been sent yet?
Yeah, I was typing into nothing, so it should be on the screen now. I was typing away and it was going nowhere.
All right. And remember, no shame, no judgment. This is the culture that we live in. And while I'm waiting for everyone to put up their response, I'll give another example of what this looks like. I was working with a set of twins in my office. One is underweight and one is slightly overweight and has high cholesterol. So the family is working on 2 very different food dynamics in that home. And one, they're constantly wanting one child to eat to gain weight. And then they're telling the other child not to eat as much to not gain weight. And we worked a lot on learning what fat is, what our organ systems do, how our body serves us in office. And the kids came out empowered. They're ready. They know what their body does. They're feeling good about themselves and what their heart does, what their brain does, how their liver and kidneys work. And the parent comes in and the child shows them, I have a fat model in my office. And the child picks up the fat and goes, look at this fat. It's amazing. Like, this is all the things it does. And the mom immediately went to her own belly, grabbed it and said, oh, I got a lot of it here. I need to lose it. And the child's face just dropped. And she said, Mama, why would you say that? Why would you say that about yourself? And it struck me as being so powerful that we say these things without even thinking about them. And we all do. We say it without even thinking about it. And after this child will just learn so many great things about their body and about fats and the things that it does for us. How that message just like took her back. Like, wait, you're one of my favorite people. What's that about? So I'm going to bring this down so I can take a look. I hope no one's laughing at my tabs yet. I have so many tabs.
Not at all. I want to say a comment too. When I was like in my undergrad and I was living in Tampa, I used to go to the Whole Foods in the area just to buy certain supplements. And there was a sign outside the door and it said something like, love your body like it belongs to someone that you love. And I love that because when I saw that, I agree with you you always hear like people like kind of like shaming their bodies. Oh, I hate my body. I hate my stomach. I hate the way I look. And it becomes such a normal thing because everybody around you, most of them, they say that they're very unhappy with how they look or whatever the case may be. And when I saw that outside of like the store, it just like, it kind of like stopped me. And I was like, you have to treat yourself with respect. Like if it takes for you to think like, pretend your body is like someone that you love, you wouldn't treat them the same way or talk to them the same way that you will talk to yourself, like in that kind of tone or like shaming wise. So I just wanted to say that as well, because I just wanted to piggyback on what you said, that it's such a norm of shaming ourselves.
Yes. Yes, completely. Yes. Love yourself like you love your kids, like you love your parents, like you love.
Yeah.
And that example I just gave of that child, like she loves her parent. So she does not see that there's a flaw in her parent's body. She came from her parent. So, this is who I share my genes with. And so it looks like for most people, the answers here are really reflective of the US culture. For most, we've done something to try to modify our body through diet or exercise for the purpose of weight loss in the last year, at least 3 times. I saw someone put like at least 5 times. I know the pandemic has given us a lot of opportunities to do those things. So keeping all of that in mind, all of that in the back of our head, we want to focus on disease prevention and not weight control. Weight will come when we are whatever you want in terms of your weight will come when we're doing the right things for our bodies. So we're focusing on that. We're focusing that with the adults that we're working with, who are the parents, and with their kids. So we're going to cut through all of this other clutter as a healthcare provider to provide that really relatable, evidence-based information, guilt-free information. We're trying to remove stress and pressure and not add it. A lot of times we talk about healthy food, we are adding stress. I have so many patients who come to me like, you're going to be so mad at me. I'm like, no, why would I be mad at you if you didn't meet the goals that we talked about? We're not here for a value judgment. It's what kept you from making those goals. If the goal was to add a vegetable with every dinner, what kept you from that? Was it time? Was it money? Were you trying to go too high and get everything from the farmer's market when you had no time to cook all that food? Do we need to teach you how to, if you get something from a farmer's market, freeze it and prep it? Like, what do we need to do to make this more accessible for you? It's not about letting down the provider, but boosting up the parents so that they can make the best choices for themselves and their families, and they can learn. And when our parents learn to adapt and learn to make these healthy choices fit any budget, any life circumstance, any amount of stressor, if they're on the road, at home, then their kids see this. Their kids see how their parents adapt. Their kids see how their parents move, how they talk about themselves. And it changes how A family thinks about food and sees food for generations. So stigma, oh, our beautiful stigma. It forms when we isolate parents from parental feeding choices that they have. So parents are making the best decisions they can based on the information that they have. That information is typically coming from other parents or their own parents. Parenting apps are about 50% of where that information is coming from. Then websites like WebMD, CDC, celebrities are a huge one. And this data is from 2019, it was published in 2020. So we're going to see how this has shifted, in the year to come as we've all been home and a lot more reliant on social media and internet sources. What role that our Instagram celebrities have in this. But low-income parents do not tend to seek out sources outside of their own parents as much. Same for individuals with lower education, with high school education or under. So that their own family is a really big source of information. And so America has a very unique culture of seeking out a large amount of parental advice before making a decision. We don't just ask one person. We don't just ask so they're not just going to ask their WIC nutritionist. They're not just going to go to one website. They want to get like 10 different sources that say all the same things, which can be tough or easy. It also creates a bigger level of anxiety about doing something wrong when you're seeking out this much external validity for a decision that you're making, because there's so many different kinds of kids, there's so many different family structures that it's easy for something to feel very wrong. And mothers specifically say that they sought advice to be more organized, calmer, better at multitasking, and dealing with their infant and child emotions. Whew, those are tough things, to get more organized. To get calmer, better at multitasking. Those are tough when you're looking for external sources, especially if you're seeking, these social media sources, which are often quite perfect of what organization and calm life and self-care looks like. So other sources of parental education: podcasts, classes, books, magazines, support groups are still incredibly important. We're going to talk about this afternoon. Whether it's Facebook groups, listservs, baby cafes, the Leche League, any sort of support group are also where parents are seeking that information. So when we talk to, I'm just trying to move this over. So when we talk to parents, we want to use language that makes them feel empowered. We do that by creating connections, by offering empathy, understanding, by not letting them talk down about themselves. If I hear someone, tell me that they failed at this or that they're bad at this, or, this is my weakness, we change that around. Your love of sugar is not your weakness. Our bodies are biologically designed to want sugar. It's the only thing our brains eat. There's not something wrong with you because you like sugar. We're going to modify the amount that you're taking in, but what you're feeling is not invalid. What you're feeling is not this bad thing that's just you. And so we want to speak in that language and make sure that when we're hearing the families that we work with speak about themselves in this way, that we're switching that around and affirming them, using storytelling as a tool and explaining everything at a third grade level, as simple as you possibly can get it. That is an amazing tool to use, to take all the clinical language out. Peer counselors are great at this, and taking everything and bringing it down to that third grade reading level. Oops. All right. So I talked a little bit before in that first hour about sugars and kids. So not many people realize that there are new recommendations on sugar intake. For kids from 0 to 2, it is 0 added sugar. zero added sugar in their diet. And these are American Heart Association recommendations. This is also why you'll see on food labels that they've changed it to having the amount of added sugar in a food. And you'll see companies trying to change in suit. It's because of these recommendations, because we now know that added sugars can be detrimental if there's too much. So kids 2 to 18, less than 25 grams or 6 teaspoons of sugar a day. This might seem like, oh, that's easy. We can do that. Ketchup usually has, somewhere between 8 and 12. So these can add up really, really, really fast. Muffins can have 24. So these can add up incredibly fast. And not many parents know that this even is a recommendation. So how do we help folks identify sugar? The trouble is that we talk about sugar in ways that don't sound like sugar. We also talk about, we give this health grade to different kind of sugars, like, oh, high fructose corn syrup, that's bad, but coconut sugar, that's really good. Honey is really good. But in our bodies, they all become the same thing. This is another one. We want to take the value judgment off of the types of sugar, and then instead focus on our healthier sources. So we want to change the way we're talking about sugar. It's not a treat. It's not a reward. Like, nix dessert from our vocabulary. It is just a sometimes food. Sometimes I want a cookie. Sometimes I want ice cream. There's no guilt around that. It's fine. Sometimes. Not every day. Not always, but sometimes. So in changing the way that we think about sugar, I'm inviting you into my kitchen like 5 years ago. This is my home. And that is my daughter. I think she was like 3. And she woke up that morning. It was July. You can see by her shirt there. It was July. And she said, I want to make gingerbread cookies, even though it's not Christmas time. And I said, okay, we'll do that after school. We'll do that today. And so we came home, we got all the ingredients out. We made the cookies from scratch. We made the icing from scratch. I had her ice up every cookie, take them all out, little dinosaur shapes, all different shapes. We did that all. It took about 2 hours. We destroyed my kitchen, as you can see in the background. And then she took one cookie and off she went, super happy. So you want to make it fun and spontaneous, and, saying, no, we're not going to make cookies, that's an unhealthy decision. That puts a stigma on it. We want to take that stigma away. Like, sure, let's do this as a family. Let's make an activity out of it. And then we grab one and we go. And that's it. Making things together is also great. Or going out on a special time together. Like, oh, we're all going to go to the ice cream parlor and get our favorite ice cream with toppings, rather than just keeping that Breyer's ice cream in the freezer and just constantly eating it every day. Make it spontaneous. Don't make a huge deal out of it. We're just keeping things as light as we can to change the stigma we have around sugars and food. And then budgeting. So a lot of times families say, well, where am I going to get this money? You're talking about, all these healthy foods. What are healthy foods? Like vegetables and all this other stuff. Where do we find the money? We often find the money in the unhealthy foods we're eating. We take out the juice, we take out the soda, the sweets, the candies, and all that, and we replace it with frozen or canned vegetables. We replace it with the cheapest food ever, beans and lentils. We replace it with staples like rice. We replace these things, and it's really easy to make that budget change. But we need to have the education to make that budget change. And we need to be able to show them where that money can come from and how to use their WIC dollars. I made it. 10:28. We made it, you guys, in time. So with that, I'm going to stop sharing my screen so I can see all of your questions. Let's see. I've never done that part of the talk so fast. All right, so one coming in for Anna. about a list of resources for obesity complications and outcomes for pregnant folks. Well, definitely, there's a giant list of resource slides that I can send, that we can make sure are sent out to the group. So we can definitely do that. I'm wondering if are you factoring the newish knowledge that there is no evidence for BMI as an individual tool, and especially not a tool for women or pregnant people, considering its origin as a population tool derived only from data sets of white European men? So that data is a little skewed, and that BMI is not just based on white European men. BMI is based on a population total. And as we said, it is a tool that there's very well-established data behind. So we know beyond a shadow of a doubt that individuals with a BMI between 30 and up, that BMI, which we call obesity, that BMI has an increased risk of heart disease, diabetes, metabolic disorder, cancers, all of those things. And so, yes, it's not once again, not a value judgment. It's not any of those things. It's just, this is what we have decades and decades and decades of data demonstrating that these particular sets of BMIs are correlated with these diseases. And we're seeing, and because of those biological factors of what fat is and what fat does, those are just our scientific data and resources. But definitely we'll get those resources to you. There are so many. Let's see. And then Tina says she doesn't have a question, but she recommends the Sugar film. It's a well-done documentary on added sugars. There's also a book called, I believe it's just Sugar, that's really informative on how sugar has shaped who we are as a culture, let's say worldwide culture. Then Sienna asks, do you work with people with food tolerances such as gluten or dairy free, etc.? If so, I would love to know what your thoughts or advice you may give. So yes, we work a lot with individuals with different types of sensitivities, allergies. I have some of my kids who are allergic to everything under the sun, it feels like. And once again, that's a part of finding resources. So I believe strongly in go into the grocery store myself, looking on Instacart myself, and seeing what is in the grocery store, where they would get it. We actually have lists that we provide at Peapod to our parents who might have a new dairy-free child of like, here are the list of everything that is at the grocery stores here. So here are grocery stores: Whole Foods, Publix, Kroger, Sprouts. We have a couple little ones, Target, Walmart, all of those. So we have actually gone into those stores and said, oh, you shop at Walmart? No problem. Here's where that stuff is. It takes a whole lot more work, but I grocery shop anyway, right? So why not take the time to go find out what products are out there at all these different stores, so I can tell folks where to go. Like, oh, did you know Walmart has this section, and usually you can find these things on sale, and do you know on your WIC vouchers, what is available here and there and where you can use them. So that's also really important as well. Let's see. So Lexi says, I think for BMI, there are more accurate tools that identify fat percentage like DEXA scan, but BMI is a quick and easy tool that has significant evidence based on health associations. Absolutely, Lexi. And you bring up a point too there. So BMI, once again, is not talking about a body fat percentage. And a lot of people link it with body fat percentage. It is just a tool. It's not the only tool. And of course, a DEXA scan, which is much more expensive, but really cool to get. I've had some before, can tell you your exact body composition, but it's just a great tool to have. And we love it too in office. When I have someone who's moved from, their goal is to lose weight. And I always kind of focus away from the weight loss goal and the health and move it to a health goal. But when they move from like a BMI of 40 to a BMI of 39, oh my gosh, the party that we throw. And it could be like a 5-pound difference, but then we talk about like, be excited because you have just decreased your risk of all of this whole list of diseases, you have just bought yourself an extra bit of health. So, I know you want to lose like 100, whatever, you want to lose this weight, but let's think about it from a health standpoint of where you just moved. And that's amazing. That should be celebrated. And so every little bit, we always connect it to health. Everything always goes back to health. Weight is never just there for weight's sake. And then lastly, I'll make my last question here for Rachel so that everyone can get to break semi on time. Do you have any resources to share on family meal planning and introducing infants to solid family foods? Actually, the USDA site under their WIC information has a plethora of information on starting solid foods for little ones. There's so much more out there than just like the blogs and that. But the USDA site, I actually have it pulled up here. The USDA has a site that is just for all the WIC programs, and they talk about starting solid foods and what are those cues. CDC is also a great source of recommendation for that evidence-based information to send parents to. So there's a lot of evidence-based information out there, AAP, all of it. It's just pointing those families in that direction. Let me bring back my screen here. All right. Oh, Elena made a really good one. Okay, Elena, and then that's the last one. So Elena said, I wonder if juice will be taking off the food package for 1-year-old under WIC if the new update is to offer juice after 2 years. Just wondering. I don't see that's something that's probably going to happen anytime soon. I know one of the children's hospitals here got a big grant to get that message out through radio ads, and they had billboards and everything about juice for young children and how we should not be giving juice to young children. But it's an incredible amount of funding over a sustained period of time. It was so exciting to see those billboards, so exciting to hear the radio announcements and things like that. But it is tough to get that funded. And those changes often take a long time from the data to be there to big institutional changes. But we have the data, and so that's a great place to start. All right, y'all. With that, I will turn it back over to Sam to start our break. And I look forward to seeing everyone again this afternoon.
Great. Thanks, everybody. Thank you, Alicia. Kyle is going to pop up a timer for us. Let me see. I think it's 15 minutes. So we will see you all back. And just so you know, this background on the slides, this is Maine. I know it's a little bit difficult to see, but it's the land acknowledgement. So you can see which areas of Maine were associated with each tribe in the area. So that's the land acknowledgement slide, but we'll see you back in 15 minutes.